Hi, I'm Tim Emory, an MD. I'm also a radiologist. I specialize in breast imaging. There's two ways we find breast cancer. We find it with screening and we find it when you have problems. So let's talk about the problem part first. Mainly a problem is if you notice a problem in one part of one breast getting worse, that's what we need to look into. If a problem is there for 20 years and hasn't changed, it's almost certainly not cancer. If you've noticed a lump for a year or so, could it be cancer? Yeah, it could be cancer. So that's what diagnostic mammography is about, is to look at patients who have problems. We also do breast cancer screening, of course. That's for patients who don't have problems. There's two types of screening. There's a main type of screening for average patients who are at no special risk. And then there are people that are at high risk. We're looking into ways to identify high-risk patients and get them referred to a high-risk clinic that we have here at the Breast Center. As far as women at average risk, there's a lot of confusion about screening. Do I need to be screened? What age should I start screening? How often should I be screened? The chance of getting breast cancer is much higher in your 40s than your 30s, which is why the American Cancer Society believes that getting screened beginning at age 40 is the right move. You're slightly more likely to get breast cancer in your 50s than your 40s, and you're more likely to get breast cancer in your 60s than your 50s. As you get into your 70s and 80s, the benefit from screening is still there, but it decreases because you're less likely to live as long if we cure you from breast cancer. If you decide you want to be screened, you're about 40% less likely to die from breast cancer. But there are costs involved, not just monetary costs. One cost is the fact that you have about a 1 in 10 or 1 in 20 chance of being called back for additional views from a screening mammogram. What do I mean by that? Well, about once every 10 to 20 years on average, if you get an annual mammography, you could be called back for additional views. Most people who are called back don't have breast cancer. It just means that we can't quite tell, and we think we're a little bit worried about something, and we need to call you back. Another cost is getting a biopsy when you don't have cancer. So if we call back 5 or 10 out of 100 that get screened, then about 1 out of 100 ends up getting a biopsy. So you have basically a 1 in 100 chance of getting a biopsy. The average woman will get a biopsy once in 100 years. So that's one of the costs of screening. And for every 10 women that get a biopsy, only 3 of them actually have cancer. So there will be 7 that get a biopsy that don't have cancer, and that's one of the costs of screening. How about radiation risk? Radiation exposure is extremely low. When you're talking about tens of millions of women, then radiation comes into play. For an individual woman, the radiation risk is low. If you are willing to take a plane trip from here to New York, then that's the same amount, roughly, of radiation that you get with an annual mammogram. To summarize, when we look for breast cancer, there's 2 methods: diagnostic mammography and screening. Diagnostic mammography is for women that have problems, usually something in one part of one breast that is considered a problem, a lump, pain, something like that. And screening mammography is for women who don't have problems. And not everyone needs to be screened, but if you want to decrease your risk of dying from breast cancer, then screening is an option for you.